Mm-hmm. Oh.
Corinne, can you see the chat box on the right, down by the bottom? On the bottom right-hand corner, there's a chat bubble. Just click on it, and that way you can send me a message, or I can send you a message there if you need to.
Hi, Shane. Uh-oh. They muted you. They won't let you unmute.
There you go.
There we go.
Thank you very much for joining us.
My other devices so that minimize the dinging. Today,
the President of the United States joined our caucus call, and as it would be with every 78-year-old, he had to be reminded to unmute himself. So, it happens to the best of us. Thank you for joining us.
That we are live.
I know. I didn't say anything bad.
So you know.
With great affection for the Chief Executive. Marianne, we're going to start in 1 minute. Let me know.
1 minute.
Okay. Shane and Corinne, Marianne is my Chief of Staff. She's based in San Diego, and she's going to moderate tonight. And I have a couple other people here who have helped me set this up, including Daniela Contreras, who's in San Diego, and Ali Pulaski, who's out here. And so if it goes wrong, I have plenty of people to blame.
Got it. All right. Well, yeah.
They have the House of Representatives using the system called WebEx, which is not super intuitive. So hopefully it's all worked out. I'm trying to unmute Corinne.
Marianne is probably the best person in communications and the iffiest person with technology.
True. Now she's unmuted.
Okay, good.
All right.
All right. I got 8 o'clock. You got 5 o'clock. I'm ready.
I'm ready. Well, thank you, everyone, for joining us. I see that the attendees are logging in, and we have several on already, and the numbers are going up, so we're going to go ahead and get started. Thank you for joining us for this virtual town hall with Congressman Scott Peters. I'm Marianne Kintar. I'm Congressman Peters' Chief of Staff, and I'm going to be moderating tonight. We're going to be discussing the efficacy and the distribution of the COVID-19 vaccine in San Diego. We're very honored to have two special guests with us, Dr. Crotty from the Jolla Institute for Immunology, and Dr. Corinne, is it Corinne or Corinne? Corinne McDaniels-Davidson. She is the director of the Institute for Public Health at San Diego State University, Go Aztecs, joining us as our special guest. Before we begin, a few reminders. If you'd like to ask a question and are joining us via WebEx, please use the chat function at the bottom right corner of your screen. If you don't see it right away, if you move your cursor around in the bottom right-hand corner, there is a little blue chat bubble, and that will let you send a chat to us, and I will help get the questions to our guests. If you or your friends are having problems logging on tonight, you can always watch the event on Congressman Peters' Facebook page, which is streaming this event live now. To ask a question from Facebook, you just post your question into the comment section, and we have staff monitoring the Facebook questions and getting them to me. When we get to the Q&A portion, I'll get questions to the panelists, and I think we covered that. So without further delay, I'm going to turn the event over to Congressman Peters.
Thanks, Marianne, and hello, everyone. Thanks for joining us. I'm Congressman Scott Peters. I'm very proud to be your representative in San Diego. January 21st marked the one-year anniversary of the first confirmed case of COVID-19 in the United States. Since then, our country has grappled with this ruthless public health crisis that has now claimed 447,000 Americans' lives, including 2,629 San Diegans at last count. Now, I'm referring to these tragically lost lives as numbers here for context, as we kind of consider the depth and the magnitude of this tragedy. But we know these numbers aren't just statistics. They represent mothers, fathers, grandparents, husbands, wives, daughters, sons gone forever. So today we're going to talk about vaccines and the path back to normalcy. But I don't for 1 minute lose sight of the fact that for the families of those who've lost a loved one to COVID, life will never be the same. What gives us hope as we look forward is the development and approval of vaccines. The distribution is underway, as you all know, but getting them into people's arms is a monumental task. Now, I have to give some credit to the previous administration for Operation Warp Speed, which took much of the financial risk out of the process of developing vaccines and led to the approval of safe and effective vaccines in record time. However, the Trump administration had virtually no federal plan for how to boost production or how to ensure the distribution once the vaccines were invented. The COVID-19 response released by President Biden and Vice President Harris is a strong start to getting the country back on its feet. President Biden has already invoked the Defense Production Act, which will help ramp up production of vaccines and supplies. And the Biden COVID-19 response team is seeking innovative solutions like specialized syringes that can extract a bonus dose to ensure every vial of vaccine is put to the best use. Last week, the White House announced plans to purchase 200 million more vaccine doses to help reach their goal to distribute 10 million doses each week for the next 3 weeks. And if the plan is successful, every adult in the United States should be vaccinated by the end of the summer. We also need congressional action. Another COVID-19 relief bill is in the works. We started that process today to provide crucial funding for vaccination deployment. Now, you will hear that Republicans and Democrats differ on the details of the COVID proposal, and that's true. But virtually everyone agrees on the need to fund vaccines and to distribute them and to provide federal money to support those efforts. Experts also point to the importance of thorough and standardized collection of complete data as part of the public health response in vaccine distribution. I've learned as a member of Congress that every state reports different data to 13 different federal agencies. And that's what drove me to author the Health Statistics Act, which I'm reintroducing soon, to ensure that the critical information is collected and made accessible to important decision makers, analysts, researchers, and public healthcare providers, so we take the right actions and allocate the right resources to deal with this problem, and also that we're better prepared next time something like this comes along. Now, as we move forward tonight, I want to remind our audience that the county and state play different roles from the federal government in the fight against coronavirus. These efforts don't always overlap, but it's certain that strategic collaboration is key. That also may mean that, we can't probably answer questions about how long the line is at the Petco distribution site. That's more of a county issue. But as the situation continues to evolve, I want to stay in touch and hear from you on our end about what we can do to be a resource to provide you current information, what we can do in Congress to support the production and deployment of vaccines through state and local governments and directly to pharmacies. So follow my social media accounts on Facebook, Twitter, and Instagram. Sign up for my newsletter. All of these you can find on my website at scottpeters.house.gov. Now we have two great guests with us tonight, San Diegans who are experts in the field, and they're each going to make short presentations to talk about their observations, and we'll follow that with questions. So with that said, I'll welcome my first guest, Dr. Corinne McDaniels-Davidson. She's an epidemiologist and a director of the San Diego State University Institute for Public Health. She leads Communities Fighting COVID, which is a partnership with the San Diego County Health and Human Services Agency to provide contact tracing to 4 of San Diego's marginalized communities. She's also a co-investigator on a National Institutes of Health grant to improve rapid testing access in marginalized populations. Dr. McDaniels-Davidson holds a PhD from the SDSU-UCSD Joint Doctoral Program and a master's degree from San Diego State in Epidemiology and Public Health. She earned her BS in Community Health Education from Ithaca College in New York. Corinne, it's great to have you with us. Why don't you give us a few introductory comments? Then we'll hear from Dr. Crotty, and then we will go to questions.
Thanks so much. It's an honor to be with you all. I'd love to talk about where we are right now today from a public health perspective. It's been a really hard year, but we've come so far. Last summer, we were struggling to get people tested during the summer surge here in San Diego. We were able to get our numbers down only to see the summertime case and hospitalization and death rates absolutely dwarfed by the Halloween, Thanksgiving, Hanukkah, and Christmas surge upon a surge upon a surge. We're hopefully coming out of that surge now, and we have vaccines that are becoming reality for many people. And this hope, though, is a funny thing, because we still have a long road to walk before we're out of these woods. It's going to take time to get people vaccinated, and now that we have more infectious variants, that they're going to put our pandemic fatigue and our public health measures really to the test. So now is the time to come together, make sure that we can all make it out the other side of this pandemic, especially the marginalized communities that have been hit hardest by this pandemic. And we can do that, yes, by getting vaccine when it's our turn, but also by paying attention to 4 key things when we need to be around others, especially if we're around others indoors. Number 1 is time. The less time that we're indoors with others is better because that's less opportunity for transmission. Number 2 is distance. More distance from people inside is better. There's nothing magic about those 6 feet. We just know that the risk is increased the closer you are to other people. Number 3 is ventilation. More ventilation is better. Open windows, good HVAC systems that bring in outside air. And number 4 is masks. And when I say masks, I mean a really well-fitting mask. If we can all pay attention to these 4 things and make sure that our essential workers are protected with distance, ventilation, and good masks, then we can get there together. Thanks.
Thanks very much, Corinne. I appreciate your summary of things that will come as no surprise to people who've been following them, but it's a good reminder, right? Dr. Shane Crotty is our next guest. He's one of the world's leading vaccinologists, and he's been at the forefront of COVID research. He's a professor at the Jolla Institute for Immunology Center for Infectious Disease and Vaccine Research, and he's made a series of important COVID-related discoveries. That have accelerated the race for a vaccine, including co-publishing a landmark study that was actually referenced by none other than Dr. Anthony Fauci during his congressional hearings last summer. Dr. Crotty earned his BS in biology and writing from MIT in 1996 and his PhD in molecular biology and virology from the University of California in San Francisco. In terms of our 2 guests, it might be fair to say that Corinne focuses on the effect of the virus on populations, and Shane knows more about the effect of vaccines and the virus on the body. And Shane, if I characterize that wrong, let me know, but why don't you give us a few opening thoughts?
No, I think that's an excellent summary, Congressman Peters. I would just say our team here at the Jolla Institute for Immunology has really become pretty world-renowned for the COVID-19 studies that we've done in the past year from my lab and Professor Alex Setti's lab and some others at LJI, which actually has largely come from studying San Diegans with COVID-19 who were generous enough to provide us with blood donations. And from those studies, we were able to learn what good immune responses look like to this virus that have helped inform and support vaccine programs over the past year. And I'd say our most recent study was looking at how well does your body remember the virus, and that was published pretty recently. But yes, you pointed to a big highlight to us as scientists in the past year, which was Tony Fauci holding up a copy of our paper in Congress and explaining T cells to Congressman. That was that was fantastic for us. I told people I should just have business cards that just have that photo on it. That would be it.
That would be a career highlight.
But yeah, I'd be happy to talk about whatever questions or aspects of vaccine biology that you'd like to, or open up the Q&A later, as you wish.
Well, I want to take the prerogative of asking the first question of each of you, and I'll start with Dr. Crotty. Let me ask you, it looks like the AstraZeneca vaccine did some extra research to determine whether someone who's vaccinated can carry a disease, and that Pfizer and Moderna may not have collected that data. But how likely is that? How likely is that to happen with a typical vaccine, that you would be vaccinated, be immune yourself, and carry it to someone else? And then I'd ask Corinne to follow up with that. How will our behaviors change as a result of being vaccinated? If you had, start to think about numbers of people vaccinated, if it's two parents but not a kid, and two grandparents but not the younger people. So maybe I could ask you both to respond to that question that's kind of out there now as vaccines start to get deployed.
Yes, that's a really good question. And there's no direct data, well, let's say there's no comprehensive data on that question right now for the two vaccines available in the U.S., the Pfizer vaccine and the Moderna vaccine, which is, it's very clear that both of those vaccines are incredibly effective at preventing COVID in people, preventing people from having symptomatic disease. It's like 95% effective at it. And they're essentially 100% effective at preventing hospitalization. So they stop the disease, in anybody, any age group. But do they prevent the virus from replicating and transmitting, which is what you're referring to, is still an unknown, because that wasn't directly measured in those clinical trials for good reasons, which was it was much faster to do the clinical trials without having that additional burden of trying to do all that sampling from 30,000 people and instead depend on the much more simpler job of counting up how many people actually got sick. Okay. For these specific vaccines, I'll go ahead and say that there is actually some data from the Moderna clinical trial that says even after a single immunization with the Moderna vaccine, most people, there's a significant amount of protection, which probably means most people can't transmit the virus even after a single immunization. So I actually think it looks good. But for any formal recommendations, they definitely need a lot more data, because that was kind of a bonus piece of data they got from the study. It wasn't the main part of the study. It does fit with expectations about the way the vaccines work. The vaccines are probably mostly preventing infection. And then if you get infection, if you still get infected, there are other parts of your immune system that the vaccine stimulated that help you shut down that infection. You specifically asked about sort of scenario A versus B. Are there vaccines that don't do that can keep you from getting sick but fail to block transmission? And there are. Most of them, if they prevent disease, they also prevent transmission. The pertussis vaccine, to me, is probably the most notable exception. The current pertussis vaccine generally prevents disease, but it turns out it probably looks like it doesn't prevent transmission, which is probably one of the reasons we've seen more pertussis over the past few years. I'll pause there.
My sense is, and I'll turn this over to Corinne, but my sense is that you would be surprised if it didn't block transmission. You just don't have any data, and that's the reason why Corinne doesn't want us to change our behaviors very much. And I'll let you fill us in on that. Dr. McDaniels.
I talk to my family and I talk to friends, and I admit that scientists are really annoying because we're so careful about the recommendations that we make. We base them on solid, sound data. And so right now, because we don't have that solid, sound data, that's why there's a recommendation that even if you get the vaccine, you still continue to mask and distance and observe all of those public health measures. We're just so careful about that, because if we make a mistake when we're talking about a population of 330 million people, that's a huge mistake. And so we're very, very careful about that. Now, I agree with Dr. Crotty that there are indications that things are looking good there, but we're going to wait to make that recommendation until we're sure that we're ready to make that recommendation.
Before I go to Marianne, just on this, does either of you have a feeling on how long it will be before we know? I mean, we're going to have experience with people having the vaccine. Will we be able to measure transmission so that, parents can see their kids again?
So I can jump in first. So those data are definitely being collected, or data that will be sufficient for the inference, and those are actually going on in the current Pfizer and Moderna clinical trials. So like those clinical trials didn't stop when they succeeded. They are continuing to track people for a period of time, and they can also go back to the people who did or didn't get infected, or just other people in the study. Basically, what you can do by doing that, accessing those people, is if you actually get infected, you'll make a different antibody response. You'll make a different immune response than what the vaccine elicited. So you can measure, okay, all these people got immunized. If those people also got infected, they'll have this other thing. And so they can go back and count. And if the vaccines prevent infection, they definitely prevent transmission. And so I would guess in a month, actually, there'll be that data. Yeah. Corinne?
Yeah, I agree. And as soon as we see the data, I'll be the first one after I'm vaccinated to throw my mask away. But I'm holding my mask for now.
Okay. I will say one reason for public health officials to say this is that some people have the mistaken impression that as soon as they've received the vaccine, they're protected, right? And that's definitely not true under any circumstance. That the vaccine, it does take at least a few weeks for your immune system to respond. And so that's one way of just reminding people to not change their behavior once they got that shot in their arm. Sorry.
And everybody's a little bit different, and you might not respond the same way as others to the vaccine. And so you don't want to make a recommendation and then someone does throw away their mask and they do get COVID later on down the road. And so we're pretty careful about it.
Okay. Marianne, I know we're getting questions already. Why don't you throw a couple out there for us?
One of our attendees has a question about how the vaccine efficacy is being tested. So here's the question. Will any of the vaccines be directly tested by exposing those with who received a vaccination to confirm its effectiveness instead of inferring effectiveness by looking at differences in infection rates in test populations? I think what they're asking is, are you actually going to test folks by exposing them, maybe? I think that's the question.
So the way that we
tell us how they're being tested.
Sure. The way that we test these kinds of drugs and pharmaceutical interventions is through this gold standard randomized controlled trial. And it really is the best way to go about it ethically. Now, we don't want to test something that we're not sure about the efficacy and then directly expose people to a pathogen would be incredibly unethical. So what we do is we recruit people and we have these randomized trials where some people get the shot and some people get a placebo. And these are blinded so that the person doesn't know what they're getting and the person giving the shot doesn't know what they're giving. And so through this kind of double-blind process and with enough numbers, both of these groups are generally equal just by the law of numbers. And so that's how we determine these kinds of trials. Dr. Crotty?
So you actually do that, but I guess I'm sorry, I thought they answered the question, but Dr. Crotty wants to add anything. But there's another question that's related about whether there's disaggregated data on efficacy by population groups like Latinos, African Americans, Asians. Do you know if we have that?
There is. I can jump in on that one. And actually, first of all, these are some of the largest vaccine clinical trials ever done. So actually, there's a fantastic amount of data available just in general. So the findings really are quite robust. And then second, not only did you have one amazing big clinical trial, you literally had two that were almost identical, right, but done independently, completely blinded from each other. And they both got the same results. Both the Pfizer and Moderna got 95% efficacy. So there's really a very high level of confidence in these findings. To get that amount of reproducibility in medical trials is very uncommon. So then to directly answer the question, these are actually the most inclusive vaccine clinical trials ever done. There was a very active enrollment process that they did to make sure that various populations were included. Certainly the people over the age of 65 were included, but also Black communities, Latino communities, and other communities were represented. And so in fact, yeah, the efficacy and safety are essentially equivalent in all of those populations, and they have deaggregated. Some populations didn't quite have enough total events to make a formal statement, but when they look across all the populations, it was actually really very nice, and all that information is public, and that efficacy was at least as good in the Black and Latino populations as the white populations, and it was fantastically good in people 65 and over. So yeah, same thing with safety. There's really good data for both of those.
It's been said that this is the best vaccine ever created. Is that hyperbole?
That's hyperbole. I mean, they're the fastest, and this is the only time in human history that there have ever been two successful vaccines developed within the same calendar year, right? Much less developed within 12 months of the discovery of the disease. So there are a whole bunch of firsts that these vaccines definitely deserve. But best probably isn't one of them. They're incredibly good, but there are a number of vaccines that are incredibly good.
Good. Okay. Marianne?
Sorry, I'm trying to mute myself. I'm not talking. There was a question about misunderstandings about the vaccine, and maybe this is a question for either of you, I suppose. But what is being done to dispel fear, myths, and misunderstandings about vaccines in general, and the COVID vaccine? So, COVID and vaccines in general.
There's a lot of work being done in the public health community on vaccines in general and vaccine hesitancy and vaccine misinformation. Now, I mentioned earlier that scientists can often be annoying because we're very careful about the things that we say, and we only say things when we have enough data to say them with confidence. The problem is people who kind of put forward these vaccine misinformations and myths, they don't have that same kind of, the same things holding them back. And so it's like, something that is just shooting off paper nonstop. And on the other hand, you have us who's so careful about the things that we say. And so you can understand why people might gravitate toward the misinformation because it's pervasive. It's nonstop. It's everywhere. It kind of infiltrates everything. I have 3 young children, and when I became a mother, I became a part of these kind of mom groups, and I saw the vaccine misinformation start weaving its way into them, and it's a challenge. I work with the HPV vaccine and combating misinformation and hesitancy there in my pre-COVID life. And so it's a challenge. And then in terms of the COVID vaccines, one of the things that we're doing here in San Diego County that I think was amazing is that the county put out these contracts way back in the summer with community-based organizations and to employ community health workers and to use trusted messengers to reach their own communities to combat some of these vaccine myths, but also at the time it was to really promote the public health measures and to encourage testing and to just answer people's questions. And so this kind of forward thinking has been planted way back in the summer so that we have people on the ground giving talks and talking to people one-on-one and in small group sessions and doing advertisement right here in San Diego County. And now they're working on addressing those vaccine myths.
Yeah, Marianne, I think that's a great answer, and I think it's a really important question and topic. Yeah, there are at least 3 big ones. So first of all, I think actually some vaccine hesitancy is a normal thing for a new vaccine. It's just anything that's new, right? It's reasonable for people to want some information about it. And in fact, vaccine scientists were saying, look, before the clinical trials are done, it's definitely very reasonable to be hesitant because there's not any data, right? And so now that there's data, it's the rush to communicate as well as possible to people. And so I'd say a couple of the big ones are, honestly, one is a big myth that's been made is that people under the age of 65 are totally safe from COVID-19. So there's no need for them to get vaccinated because the disease, is no worse than the flu or whatever the myth, that people have is. And over half of the COVID-19 hospitalizations in America have been people under the age of 65, okay? It is a very serious disease in any age group. And in fact, half of those people are under the age of 50. And so as it becomes your turn to get the vaccine, it's definitely a great vaccine to get to protect you because it's not just for people over the age 65. In addition to the fact that it is the kind thing to do to protect your family and your friends and your neighbors so that you aren't passing it on to them. A second one is that it's pretty common for people to worry that if a vaccine hurts, that something's going wrong, and that's actually incorrect. Usually that's a sign that your immune system is actually responding to the vaccine. Your immune system is reacting to it and learning and making an immune response. So it's actually usually a positive sign when your arm gets, red or sore. And so I tell people it's like going to the gym and working out, right? That sometimes if you get really sore, but that can be it's a positive thing that you had that soreness. In this case you're earning your immunity. That the vaccine really does have to kick your immune system off to do the right thing. And I'd say the third one, a third one is the safety question you asked before. People ask, is there really good safety data? And yeah, there's fantastic safety data. I mean, there were 70,000 doses of this vaccine given, and again, in a very inclusive way. And so it's probably got the most safety data of any vaccine ever to first get, authorization to go into people. And finally, I'll pause after this one. People have concerns that since RNA vaccines are a new thing, right, is that different in important ways? And certainly one of the questions has been, or misconceptions has been, does that vaccine become a permanent part of your body? Because sometimes people have used the phrase genetic vaccine, and that's incorrect. That's just a misperception that's worth clarifying. RNA is just a normal molecule in your body, and they're messages. So let's say in any cell in your body right now, there are like 5,000 different RNAs, and each of them, they're like little Post-it notes. Each one of them has a different little message on them, and they're around in your cell for minutes or maybe hours, and then they get shredded up, and that message is gone. And so the RNA vaccines are the same thing. It's just adding one more message to the 5,000 that are already there to now instruct your body how to recognize this virus, and then they get degraded and shredded and go away. They are temporary messages that fade. So I'll stop there.
I would echo Dr. Crotty and say that I was skeptical until I saw the data, and I think it's okay to be skeptical. Like he said, we need to earn people's trust. And that's okay. If people have questions or concerns, they deserve to have them addressed. And I think that's why we're all here, and why I think that every person in public health and medicine and in research kind of owes it to the world to answer people's questions and address their concerns.
Marianne, there's one on the chat thing that I get all the time that I want to ask, which is sort of a really open-ended one. I'll pose this first to Corinne. What is your best guess as to when we can all return to leading a normal life without masks and self-isolating? And I know you have to make some assumptions about the deployment of the vaccine. Why don't you talk about how people should think about that, and can I take a family vacation when the break comes up in August?
I'm not making plans for August. What I told my daughter a long time ago is that my hope is that for next Halloween, we'll be able to go trick-or-treating. We might have to wear masks, but we'll be able to go trick-or-treating. Keep in mind that even if we reach our goals of vaccination in the 16 and up, we still need to de-escalate our clinical trials, which means kind of go down in the age groups to test efficacy in younger age groups and get them vaccinated. Because most kids do okay with the virus. We don't know about long-term what happens, but there are kids who don't do okay. And so we need to make sure that our kids are protected as well. I think it's going to be a little while, and this really depends on how quickly we're able to reach our levels of community immunity, because the longer that takes around the world, the more likely we are to see these kinds of mutations and variants. And I'll let Dr. Crotty kind of talk about that if he wants.
Yeah, the variants make it more complicated. I think most of us are saying right now, it's a totally fair question, of course, but for now, I think that the focus really is on sort of the next 3 months and it being essentially a race between vaccinating as many people as possible and the variants, which are more infectious, kind of spreading faster. And a lot of that is a supply side issue that comes down to how many doses are available and how quickly can they get into people's arms, I think. And it'll probably be a month from now before we have a better sense of what, how significantly the variants actually spread in the United States. The vaccines definitely work against the variants. So, so for everybody looking for good news as opposed to the sort of, next new horror that kind of shows up in the 24-hour news cycle, the positives have been that the vaccines work against the variants, particularly the one that's been in the UK variant, which is the most transmissible and is definitely the one that's significantly in the US and significantly in San Diego at this point. The vaccines essentially work perfectly against that variant, so that is quite good news. And they still work. It looks like they work fine against the South Africa. It looks like they will work fine against the South Africa variant. The 2 RNA vaccines, we don't have direct data on that, but that's the expectation.
Want me to deliver another question, Scott? Wasn't sure if you were waiting for me. I think this is a good follow-along question. Several people have asked about if once they've had the vaccine or if they have had the virus, do you recommend that they go get an antibody test? How do they know if the vaccine or when the vaccine is working?
I mean, if you've gotten 2 doses of the RNA vaccine, it's working. There's no reason to go get an antibody test based on the available data. That's the simple answer. And actually, the available tests are all non-standardized, and inconsistent, so you won't really be able to reference them to what was actually in the clinical trial. I've gotten 1 dose, because I run a COVID lab, and I'm not going to go do something like that.
I have an epidemiology question from the chat, Corinne, it's about mental health with respect to school closures. And I don't know what data are being collected on that, but we know that there are effects from kids not being able to go to school. There are effects on families. We hear, at least anecdotally, that suicides are up. And I don't know if you have any comments on whether San Diego Unified's doing the right thing in terms of reopening schools, or whether there's some announcement last week that affect your view on that. Would you give us a sense for what you think about that situation, how you assess it?
Yeah, I think I want to address suicides first, because the studies that I've seen have shown that there isn't an uptick in suicides. Now, it could be that I'm not looking at the right ones. It's not my area of expertise. But the ones that I have seen, I think out of Boston and a couple other places, show that there isn't any kind of increase in suicides. Now, when we talk about kids' mental health and families' mental health, I want to point out something that I think people can miss. People are comparing mental health before the pandemic to mental health during a pandemic with school closures. And it's not necessarily the school closures that are causing the mental health issues, it's the pandemic. And so we need to be careful about making those kinds of comparisons. It's really hard right now. It's hard right now for everyone. I work from home, and my 2nd grader is in the room next door on Zoom. And then my littles are kind of running all around. So I know that it's a challenge, but personally, I think that it has been the right decision. I wouldn't probably have been comfortable with my kids going back to in-person schooling without there being a lot more funding for ventilation, without ensuring that masks are being used, and all of those kinds of things that I talked about, the distance and all of that in place before they went back to school. Now, I know I might catch some flack for that from parents, but that is my own personal opinion and not necessarily the opinion of anyone that I represent.
Well, fortunately, they're not voters for you. You don't have to worry about voters, so you get to have your opinion. But I guess one thing I would ask, just to follow on, is what should we make of the effect of teachers being vaccinated? So we had put them in a high priority so that schools would reopen, but then you see sort of understandably teachers saying, well, I don't want to bring it home if I can transmit it. So how should we evaluate that? Should we expect teachers who are vaccinated to be in school, and is that unreasonable? What's sort of your take on that? You have one.
Everyone has their own level of risk, and that's such a hard thing to kind of weigh in on because teachers might be at great risk. The challenge that we have is that the data on school reopenings and school openings in general isn't great. The studies that have been done haven't been systematically testing kids for asymptomatic infection. And so we don't have a lot of strong data on which to make those kinds of assertions. And so it's left up to people's comfort levels. And I understand why teachers don't feel comfortable.
So I guess I'd just add that I think the available data that is around from schools that have been open have been that teachers aren't at particularly higher risk than other people, and that it seems like if they do get infected, it's from other adults, not the kids. Well, so while the data are imperfect, they do point in that direction. And just to go back to an important thing Corinne said earlier that I think is an important part of the school conversation that many people are missing is that kids can't start getting immunized next month because you have to specifically have vaccine trials for younger age groups, and you can't just have a vaccine trial for just all kids. You actually have to do it by essentially 12 to 16-year-olds, then frequently 9 to 12-year-olds, and then 6 to 12, and keep stepping it back because kids are a different category. And so there are certainly plenty of people who have said, it could be 2022 before kids from first grade up are able to be vaccinated and so, your plans and expectations should probably keep that perspective in mind that the vaccine companies are doing their best to be clear. They do have to follow rules of enrolling kids and directly showing the vaccines in those and step it down by age group. So it may be 2022. There are more optimistic views than that, but I think that's a reasonable perspective to keep in mind for trying to think about school opening. Sorry, I'll stop there.
Well, I was just going to say, speaking of optimistic views, I don't know if you caught the CDC's recent statement about the safety of opening schools. It seemed to me that was pretty comforting, but I guess you're not really, unless I misinterpreted, you're sort of not necessarily embracing that.
Well, it's not that I'm not embracing it. It's that the CDC did express comfort with opening schools if certain conditions can be met and community transmission is low, the ventilation is good, masking is enforced. And so those are the kinds of things that I don't think are necessarily in place yet nationwide and do require funding in order to make schools safe to be reopened.
Marianne?
There's a question here about this question came in earlier about how hospitals and other health providers are communicating with patients and just the general public. Do you have suggestions or recommendations about how either health providers or, I guess, those people that are elected office or appointed office could be communicating better? What message could they be delivering better so people feel safer and more secure about the vaccine?
I think it's not about the communication that goes out. I think that for people who have the concerns about the vaccine, it takes a conversation. And so I think people just need to be open to having that conversation because everyone has their own reasons for either getting the vaccine or being hesitant. And so kind of a one-shot method of communicating might not be effective. You really need to have those conversations when you're with a patient, either in a televisit or in an exam room. And the same when we're kind of out there anywhere. Just ask people, hey, are you going to get the COVID vaccine? And be open to having that conversation and hearing their concerns and validating them and then giving them information.
Want to add to that, Dr. Crotty? Or?
I think that's a fantastic point. I think it does come down to what specific, concerns people have. I listed several of the big ones earlier that I find I get questions having about, is there actually safety data or has it been shown to work in persons like myself, or gee, isn't this vaccine new? And I think there are very good answers to all of those, particularly since the vaccines work so incredibly well, and since COVID is killing and hospitalizing so many Americans. But it is a matter of having the conversation. And the more people who get vaccinated, the better it goes, as was being said, because it's just, they are very safe vaccines. They work. People get a sore arm or might feel crummy for a day, and the more neighbors and friends that or doctors that they have, or nurses that they say, yeah, I got vaccinated, I didn't feel great the next day, but then after that it was fine. That helps as well.
I had a question sort of on the other end. One of the things I mentioned in the introduction is that there's not really good standardization of reporting from state to state, and the federal government sort of is a diaspora of information in the federal government. We're trying to rationalize that. But do you either of you have opinions about what the top mortality factors are for COVID? What is it associated with? Is it a particular ethnic group? Is it obesity, diabetes, hypertension? Do you have a sense for what's the biggest risk?
So we know there are comorbid conditions. They're kind of those conditions that make it more likely that you will respond negatively to the virus or require hospitalization or die. But it's also being an essential worker and not being protected. And so I think there was a paper, it's a preprint out of UCSF that looks at the excess mortality by profession here in California. And I think the number one profession that we've seen have excess mortality, I think, is line cooks. And that's people who you're not able to distance when you're inside of a restaurant kitchen. And so the jobs where people aren't able to kind of practice those four things that I mentioned are having the greatest excess mortality this year. And I think that was data through October, if I recall correctly. So it's the job that you have, it's the household that you're a part of, it's living in multi-generational homes, it's being a low-wage worker who's an essential employee, it's not having access to sick time, not having access to the ability to call in sick even if you don't have sick time, and then spreading the disease because you have to make rent. But then there are also the comorbid conditions that also tend to be higher in African Americans and Latinos and other kind of marginalized groups. So obesity, diabetes, hypertension, all of those kinds of chronic conditions can make it much more likely that if you do get the disease that you have a poor response.
I have a question here from someone who is a healthcare worker asking if you have data on infection rates between hospital-based healthcare workers from patients. The difference, I guess, between healthcare workers that work in a hospital and other healthcare workers. Is there a difference in rate of infection?
I haven't seen that data. I don't know that healthcare workers are routinely tested. And I think that we do need to provide better PPE for the healthcare workers in, for example, exam rooms. So primary care providers should probably have N95 masks. Anyone who's in the close proximity with other people for long periods of time. Dr. Crotty, what do you think?
Yeah, I agree. I don't know if data to the contrary, or I don't know. Sorry, I don't know if data addressing the specific question, and 100% agree with Corinne's recommendations. And my sister's a pulmonary critical care doc. She directly sees patients. So yeah, I don't want doctors to have that full PPE in those challenging situations, and anybody who comes in contact with patients, 100%.
This question has come up a couple of times and been asked a couple of different ways, but I'm almost afraid to ask because I don't want to know the answer. Do you have any predictions about when life will return to, quote, normal, or when we will see herd immunity in the region, in the nation? Any way to game that out?
It's funny because one of the things that I've been saying a lot over this last year is, boy, epidemiologists are not the fun ones in the room. I don't get invited to the Zoom parties. It depends is the answer, because the problem
Everybody stopped having Zoom parties a while ago. Don't feel bad. We're just the same.
I think you're just saying that because you haven't invited me lately.
You're not doing anything.
Yeah, everyone's drinking alone in the dark because it's a socially distanced way to do it.
It depends on the variant. It depends on how quickly we're able to increase our supply chain and get vaccines. So the County of San Diego is ramping up the kind of infrastructure around vaccines, and I think they'll be able, by the end of February, to vaccinate up to 25,000 people a day through all of the different things that they're setting up, which is an incredible logistical feat. And it's kind of, if you build it, they will come. If you build it, will the vaccine come? Because they'll be ready, and they just need the vaccine in order to put it in people's arms. But I think that the thing that I want people to remember is, yes, it will be great to have community immunity in our region, but this is an infectious disease that's spread through the air. And so it's not just about our region. It's about the nation. It's about our hemisphere. It's about the world. We live in a global economy. People travel all over. And so we need to be sure that we're not just focused on ourselves and our corner of the world, but that we're thinking about the bigger picture and making sure that we're getting vaccines to low and middle income countries, and that other countries are able to vaccinate their populations too.
Let me ask a question though, because I'm not a professional in this field. If everyone in San Diego County were vaccinated, it would still be the right thing to do to help the rest of the world. But would we be worried about our own lifestyle? Wouldn't we be able to go back to school and have non-Zoom parties and things like that? I mean, is that what? Am I missing something there, or what is the effect of the world if everyone in our neighborhood is vaccinated?
I think that's a great question, and it's a fair question. And I think that the worry is that, yes, we could perhaps do that for a while. But as I mentioned, the more people that get this virus and the faster it spreads, the more likelihood there is for these mutations. And these mutations could make the vaccine that we've already developed not be effective. We've been lucky so far. But the longer it's allowed to kind of propagate out there and continue to spread, the more likely it is that those mutations could come and knock us off our feet.
I know that this is...
Wait, I think Dr. Crotty is having some thoughts about the vaccine operability.
Yeah, so some of this comes down to thresholds of tolerance for infection. Okay, so we've got two 2 approved vaccines for use in the U.S. with multiple others on the way. 6 successful vaccines in the world so far. That's phenomenal. And so far, the data from those trials and subsequently are essentially that they're 100% protective against hospitalizations and deaths, and that's really the primary endpoint of concern. And so then from that point, it becomes what's your threshold for tolerance for other levels of infection events, right? Things that are cold-like or flu-like, because obviously we don't shut down the country every year for the flu, and so that's where it gets into the range of how much tolerance is there for that level of risk, and currently it looks like that's what the vaccines will give, even with the variants, and it's a matter of getting those vaccines into arms, and you will stop the serious morbidity and mortality. In terms of whether going back to questions at the very beginning, right? Transmissibility is a factor. So if the vaccines don't stop transmissibility at all, then there has to be a little bit different threshold. Or there has to be a different threshold because of the points Corinne brought up of, well, you don't want the virus to just be able to spread and mutate out of control. If the vaccines do a good job at preventing transmission, again, which isn't proven yet, but the bits of data that are there point in that direction, then the concerns about additional variants aren't that big at the moment once you've actually got a pretty heavily immunized population. And our knowledge about variants has a very wide confidence interval right now of it's definitely possible that essentially the virus has kind of done what it can do, and it's made the mutations that it really can, because at some point it still has to look like the same virus. It still has to be able to bind to cells and get in. But it's been a pretty clever virus so far, so nobody really wants to bet against certainly it being able to mutate more. So to me, that's where we are. I certainly hear arguments from people saying, look, once you get vaccines into people's arms to enough where you're really not going to see hospitalizations, that's it. That's what one can afford, and that's obviously way above my pay grade. But that's where the immunology is.
Lots of questions about how long the vaccine lasts. Is it going to be like the flu? Am I going to have to get it every year? Am I going to need a booster? And I think you've answered this already, but maybe talk about it again. Will the vaccine that has been developed the vaccines that have been developed so far work on the different emerging variants?
So I was laughing in the background because that's definitely, so immune memory is definitely my area of expertise. So that's basically your immune system has memory just like you've got brain memory, and just like brain memory, you remember some things a lot better than you remember others. You might not remember what socks you put on yesterday, but that intersection you almost got into an accident at, you'll remember that for years. Immune system does the same thing. The memory.
We all hope the immune system memory is better than our brain memory.
Agreed. And so we just published a big paper looking at a scientific study, actually predominantly of San Diegans who had COVID-19, asking, again with Professor Alex Setti upstairs here, looking at, 6 months out from the infection, do people still remember it? Because there was worries that people just wouldn't remember this virus. And the short answer is, it looks like people remember this virus similarly to the way that they remember other viruses. It looks like, pretty good immune memory. And there have been big studies in the UK and actually Qatar that it looks like, just by looking for protection, that there's protection 6+ months post-infection that's pretty robust. So we've predicted that people will be protected from hospitalization level disease for years after they've had COVID-19. So that's where that data is right now, ignoring variants. For the vaccines, since RNA vaccines are new, there's no historical data to reference for how well people's immune systems remember that type of vaccine. And that's really the kind of data you have to have. So it turns out for immune memory, you really have to have some reference point to compare it to, and we really just don't have that for the RNA vaccines. And that's why people haven't been making clear statements about it. So right now, the data that's available is out to about 4 months post-vaccination, and it looks like reasonable memory that it should last a year, and I'd say it's sort of a 50-50 chance right now as to whether it'll last just that long or last further. But it really is one of those things where they can't tell you whether there's memory at 1 year because it hasn't happened yet. Whereas the viral vectors, so like the J&J vaccine, may actually behave differently. So each vaccine may have its own memory profile, and so we will have to see for that as well. It'll take some time to know how long they will last. Sorry.
A couple of questions directly about the vaccine, immediate side effects.
Wait, Marianne, we're going to keep them on until they give us answers.
So they tell us exactly when we're going back to, socializing again. Someone is asking, how long can you wait before you get the second vaccine after the first one in order for it to be effective, for the dosing to be effective? And regarding side effects, would it help if I got the second vaccine in a different arm, or does that not make a difference?
I've gotten both of those questions a lot. The second one's, well, scientifically kind of a fun one, frankly. So the short answer is there's no recommendation, and so you can choose your arm. Have at it. Whichever arm you like the most or like the least, whichever way you want to think about it, get the second dose. And that one, I think certainly if somebody had a localized allergic reaction in one arm and they and their doctor still felt that they should get the second vaccination, probably the opposite arm is the obvious choice there. But outside of that, there's no specific recommendation. For the first one, wait, what was it? Oh, right. Yeah, so the first one is a good one because obviously the federal recommendation now has been to not hold doses back and just as doses arrive, use them. And so there's no dose with your name on it or my name on it for the second immunization. So you might not get that second immunization exactly at day 21 or day 28. Is that an issue? So it's true that the clinical trials had a very specific prescribed date, and so that's what we know works. But based on other vaccines and just in general, based on what we know about the immune system, it's more of a don't worry about it too much if that date is shifted by several weeks. Really, the current vaccine schedule is designed to give you the maximal protection as quickly as possible. So that second immunization was designed to be as quick as possible to get you to where you needed to be. But if you get that vaccine instead of at 1 month, if you got it at 2 months or even at 3 months, your level of immunity 6 months after that would probably be the same, no matter which date you actually got it. And so I mean, I've been telling my family that as well. That's where we're at. So don't sweat it. Definitely get your appointment scheduled, but if you're a couple weeks late, don't worry about it at all. There's actually reasonable data for other vaccines that waiting a little longer makes the response even better. Okay, so it's the best bets are that it'll be the same or even a little bump up. So don't stress about that one.
A couple of questions about the effects of the vaccine and COVID, I suppose, on pregnant women or women who are thinking they might be getting pregnant soon. Is it safe to get the vaccine?
So people in the trials were supposed to promise to not get pregnant. They didn't do a very good job, or some of them didn't, so they did get pregnant. And so the thought is that they are safe for people who are going to become pregnant. The pregnancies have all turned out fine. Dr. Crotty, I don't know if you want to add to that at all.
I do, because so that's a great answer, and I fully agree with it. And it is a question that's coming up a lot. There's some really horrible misinformation going on around that this seems to be something where people just decided to spread a conspiracy theory about a particularly susceptible population just to scare them. The data are actually, again, pretty fantastic, supporting that vaccination in pregnancy is absolutely fine, and there's definitely no infertility, which is the other conspiracy theory that's been going around. There is a really nice summary of this on Twitter by a woman. She summarized all the available data. I retweeted it a couple of days ago. Maybe I'll try and retweet it again tonight. Summarizing it, I think there were actually several hundred pregnancies in the vaccine clinical trials, and they were all fine. And actually, for a first, just to roll it back a little bit, people get worried a bit because they say, well, wait, the clinical trial wasn't specifically designed for pregnant women, and that's basically true for all clinical trials, right? They just always exclude pregnant women. That's just but for this, in this particular case, as Corinne was summarizing, definitely women did get pregnant, and the pregnancies were fine, and so the FDA, and there was a large enough number of them, that the FDA specifically allowed the recommendation we made that, yes, if a pregnant woman wants to get vaccinated at the advice of, if she wanted to and her doctor was also fine with it, the FDA was definitely a 2 thumbs up on that, and the data absolutely 100% support that.
All right, so I see a question there that I think I know the answer to, and I'm going to quiz myself. You can tell me if I'm right. The question is, I'm over 65 and getting vaccinated. My daughter who lives with me is not. Is it possible for me to pass the vaccine on to her if I'm not wearing a mask? I'm going to say that the answer you would give is, we don't know. It's probably unlikely, but you should continue to follow all the distancing and public health procedures, such as wearing a mask, just to be safe.
Pass on the vaccine or pass on the disease?
Pass on the disease. Sorry. I'm sorry.
And she lives with her, right?
They live together, yes. The daughter lives with the mother.
The current recommendation is that you don't wear a mask inside of your own house, and so I would continue to not wear a mask inside of the house.
All right. Dr.
Crotty, do you?
That is a very clever answer, Corinne. I approve. Yeah, and it goes back to some of what we talked about at the beginning, that there's no firm data currently on whether people who have been vaccinated could transmit, and so it is an unknown. The initial indications are encouraging, and that hopefully there'll be more strong data from the vaccine trials in maybe a month. Yeah, that's where we are, I think.
And it's important to know that I'm not sure if this was her question, but the vaccine doesn't give you COVID. So it doesn't give you like a killed virus or anything like that. It gives you a message, as Dr. Crotty was explaining, kind of like a Snapchat to your cells to make the spike protein. It's not to make the whole virus, it's just the spike protein so that your immune system remembers it and sees it, attacks it, remembers it later. And so if her question was, is it possible if I get vaccinated, would I then pass COVID to her from the vaccine? Then that's an absolute no.
Yeah, I think his question was basically, can she she should transmit the disease even though she's got the vaccine. So, Marianne, you can look for the next question, but there's one in there for me that I want to address just real briefly, which is, what's my prediction? Will Biden's $1.9 trillion relief package pass? The answer, there's going to give me that one. That one is yes and no. I think the one thing I want to emphasize is that there seems to be unanimity about the need to invest in vaccine production and distribution. So I think that's really good news, and I think that part of it will certainly pass. I think that the $1.9 trillion will be trimmed, and that the aid part of it will be more targeted. And I think that's probably not objectionable as well. So I like to think we'll find bipartisan agreement, but at least there's bipartisan agreement on the vaccine side of it, which I think is very good news, that we all agree that at least that's important. Marianne, next question.
A couple of people have asked this. If I were immunized with a certain vaccine the first time and it's not available the second time, what if I switch to a different vaccine? Will it still work, or do I have to have the same one both times? Same question about 1-dose versus 2-dose vaccine.
So the simple recommendation is get the same vaccine if it's possible. There are plenty of both scientific experts and public health experts saying that with the RNA vaccines, that's a gray area, and if you got one, and when it's your time to get a second immunization, if it's the other, and that's what you're offered, and they're fine with that, get it. They're very similar. Yeah, that's basically the gray area right now. Now, switching out from the RNA vaccines to a different vaccine, there's no current recommendation on, but that would be more frowned on as being there's not evidence for it. But given how comparable and similar the two RNA vaccines have been in the emergency use authorizations, that I certainly know plenty of scientists or public health people who are saying, if at my next appointment I'm offered the opposite one, I'm going to take the one I'm offered. That's going to be the same. They're challenging times, and that's the situation. Corinne, do you want to? Yeah.
No, just co-sign what you said.
Yeah. There's a question here about, and maybe Corinne, the federal government isn't involved in sort of monitoring the distribution at the local level, but maybe you have a sense for when Group 1C essential businesses might be able to expect vaccination. Are you following that close enough to give us a sense for when that might happen?
So I think that the state has already opened up 1C, if I'm not mistaken, the essential businesses, but the county has not yet. The public health officer kind of makes that call, and I'm not in on those conversations. So I think they want to get through more of the first tiers first before they get down to 1C.
And Shane, a specific question about the vaccine. People kind of want to know briefly what are the differences between sort of the RNA vaccines we talked about, Pfizer, Moderna, but J&J and AstraZeneca. What are the pluses and minuses here? We've heard different effectiveness rates, although we're told they're all very effective. Just want to say a few words about the different approaches of the different companies.
Sure. I'll say the really quick answer is the best vaccine is the one that goes in your arm. And that's honestly, that's the advice I'm giving to anybody right now, whether they're a family member of mine or not, and whether they're in the U.S. or not. That's the honest truth. They are all fantastic at preventing disease, and it's kind of splitting hairs beyond that at the moment. Having said that, it's fine to talk about are there potential strengths and weaknesses of different ones. I think the AstraZeneca has had the most complicated clinical trial results so far, so it is more difficult to interpret that one because they merged a series of different clinical trials, and so it's tougher to make interpretations and recommendations. But they have an ongoing U.S. clinical trial, and so I think it'll hopefully be clear to understand that one later. J&J released their results last week, and it looked really good. As a simple summary, there is currently a one-shot, which is obviously simpler, and it is a different platform. It's an adenoviral vector. It's a viral vector that has been previously licensed in humans for another vaccine, and so there is more long-term experience with it. Yeah, that's kind of where it is at the moment for that one. And then the other is Novavax, which is an American company with a more conventional approach of a protein vaccine, so more similar to your tetanus vaccine or your papillomavirus vaccine. And they also released really great results last week, like 95% efficacy in the UK, and so they'll be looking to try and have their vaccine be available in the US as well. So those are three different approaches that all seem to be giving pretty comparable outcomes. Yeah, that's where we are.
Marion, I know we don't have enough time to probably get to all these questions. We have a couple more to end with.
Well, there's a couple of questions related to the role of government and how government has performed during this crisis. And generally, do you have any insights or thoughts on how various states, I guess we're in California, so talk about California, shutting down, opening up. If you were in charge, what would you do? Or what would you do differently? And that's kind of a tough question, but I think people want to know what the experts would do.
I was going to say Congressman Peters is the expert in that particular scenario, so go ahead, sir.
I have well, first of all, I would just say the federal government, we do give credit for the development of this vaccine. We've learned something about how to pull along something like this that I think we can use for something like antimicrobial resistance, for instance, where there's not a natural market. If the federal government steps up and says, we're going to buy a certain amount of this, it creates a way for companies it takes the risk out of the financial side of that, and that was good. The tragic thing we found at the federal level, and this is what I'll speak to, is that to the extent that there was planning for this under the Obama administration, it really was dismantled and ignored under the Trump administration. And like I said, I did give them credit for Operation Warp Speed, so I'm trying to be fair. And there was no coordinated response. So whatever benefit we got from stopping flights or slowing flights over a month, we didn't act on getting people to intervene, and so we lost a lot of time. And then I think the data that we have is really flawed. I think it's going to be really hard for us to conclude who died from what and why based on the data we have. So that's very frustrating. I think that in general, I want to get back to the place where we're relying on scientists to help advise what to do. Now, I'm not going to, I get a lot of frustration from my constituents about the opening and closing. I feel particularly bad for small businesses who feel a little bit jerked around, whether they're restaurants or hair salons. I wish that hadn't happened, but I can't tell you that I know the analysis that went into what was behind the county and the state deciding to do that. I think it's interesting that one of the things we will be able to look back on is that there's 50 different states all providing sort of laboratories on how to handle this. And I hope we do an after-action analysis to figure out what went right and what went wrong. I particularly, as a citizen, would really love to see us concentrate on opening schools again in September, if there's any way to do that. I think that would help us not only with, someone mentioned mental health, but getting kids educated and not getting them to lose any more time. And I believe little kids are resilient and they can come back, but we need teachers. And I believe also that it's really important for the economy to get going, to have schools. They function as really important childcare. And so functionally, to get the economy back open, schools, I think, are the most important thing. And I would try to optimize around that in the next few months to make sure that come August and September, that at least we're able to get the schools back. So that's more of a perspective look than, looking backward and blaming somebody. But at least on the federal side, I think we had a lot of frustration about the last administration is really inaction on this, and I think it's cost a lot of lives.
Yeah, from a public health perspective, it was tough to see the kind of undermining of those public health measures that we were asking people to undertake from the last administration. But I think the county has done a great job. I think California overall has been a leader, and I'm just glad not to be a politician.
It's a tough job.
I know we're getting ready to wrap up, but there's two questions that I feel like they're very people really would want to hear the answer. A lot of people would want to hear the answers to this. What if I can't get an appointment several weeks after, it's later than I should have for my second dose? So what if I get my second dose later than what is recommended?
Yeah, it's fine. As we were discussing before, get your appointment when you can. Get the immunization get your immunization as soon as you can after when it should have been. I.e., if you're supposed to get it at 4 weeks and you end up getting it at 6 or 7 weeks, that's totally fine. Please don't stress about that. It's going to be at least as good or maybe even a little better long term than what you would have had. These are the things we have to give up or be flexible about so that as many people can be vaccinated as possible.
And we have one question here, maybe for you, Scott. Can wearing masks be made into a federal law? So there's some way to force compliance.
I think that neighbor to neighbor compliance is the best way to handle something like that. It's really hard to get law enforcement to want to intervene in that sort of thing. And one of the reasons why we do these, as you know, Marianne, is to get the word out about why it's so important. I think that this is something we should call on people to do as a civic act of responsibility, and I think that's the better way to handle it. Yes, you could mandate it, but it's really hard to get law enforcement to enforce. And I think the better way is to explain why it's important. And if I know that if I try to leave my office and even go to the restroom without a mask on, that people in my office will remind me to put my mask on. I think that's good, and I think those kinds of things are really helpful. I guess we're gonna conclude. I think we've come up on our end time, but I want to say thanks to Marianne and thanks to my staff for the work putting this together, but really thanks to the two panelists. It's just such an amazing thing to me to find the expertise that we have in San Diego. And I know about the Jolla Institute of Immunology, and we've spoken to some of your experts before on this. We're really proud of what you do, and you deserve all the support you get from around the world. And Corinne, I wasn't as familiar with what you do, but it doesn't surprise me at all that we have your expertise here, and we're really happy to have you as part of our community. And I did hear you're a constituent, so even better. But I'm a regionalist, so I would take you even if you lived in Encinitas or Escondido. But we appreciate the help so much. And thank you for all the education tonight. We wish everyone good health. And don't get stuck in D.C. when it's 30-some degrees. Stay in San Diego if you can. Marianne, you want to close us out?
Yeah, just thank you everyone for joining us tonight. This recording of this town hall will be posted on our Facebook page. So if you have friends who you get off tonight and you think, gosh, why didn't my friend participate? They can watch it, or something you want to come back to, it'll be there. I think that we generally covered all the questions that we got in the chat, but if you have something that you really want to get to, please send us an email, and you can find a way to contact us on our website. So thank you very much for joining us, and we'll talk to you next time. Thank you,
Shane. Corinne, thank you very much. Appreciate it. Be well.
Thank you.
Thanks, Congressman Peter. Nice to meet you, Corinne.
Likewise.